Welcome to the Myasthenia Gravis lectures. This one, pretty short. This one is also a neuromuscular issue. So the issue here is restriction to the ability to breathe, and very similar to what we see with Guillain-Barré. So with Guillain-Barré, the issue was we didn't have the muscle strength, like the signal wasn't getting there because it was eating away. It was an autoimmune that was eating away at the myelin sheath. So the electric signal wasn't able to get to the muscle for it to contract. And this is a little bit different, but sort of similar in the fact that we don't have the ability for that muscle to contract. So it's nothing going wrong per se with the lung tissue, like it's not the tissue getting stiffer or developing scars or anything like that. This is where you have the tissue of the lungs be usually just fine unless something develops, and it's going to be another thing where it's just the muscle. So it's a restrictive issue because we're restricting the ability to take a breath in. We're restricting the ability to breathe here. So let's get to it. So myasthenia gravis is the most common disorder of the neuromuscular junction. That's why I have that little picture on the side there, just to try to get into your mind a visual that this is all about the neuromuscular junction. Remember, Guillain-Barré was about eating away at the myelin sheath. This one is about the neuromuscular junction. So they have a different etiology. They have a different way of attacking the ability to breathe, right? And so that's one of the things to remember is the differences between myasthenia gravis and Guillain-Barré is they work differently. One attacks the myelin sheath, the other one is about the neuromuscular junction, and right? So that's the big thing to remember. And then the other thing is going to be which direction the paralysis goes. Well, if it goes from the ground to the brain, so if it's an ascending paralysis, then we know it's Guillain-Barré. Well, with myasthenia gravis, and we'll get into it here, it's that descending paralysis. It'll go from the mind to the ground, M and G, mind to the ground, right? So it goes the sort of opposite direction. Now, both of them can have atypical presentations that make it a little tough to differentiate sometimes, but then that's why we have testing and all this other stuff. So let's get into this. So we're looking at the neuromuscular junction, and it's interfering with acetylcholine, or ACH, right? And so ACH is what tells the muscles to do their thing. So one of the hallmark things that you'll see with this is fasciculations of muscle weakness. So hopefully you'll have some time here to pause and go YouTube some fasciculations or look for GIFs of fasciculations, right? And you'll see it's just sort of that rapid movement of muscle there. And that's what you would see here. A lot of these patients will get a lot of fatigue and weakness that gets better with rest. So they'll feel very, very fatigued. They'll go nap. They'll go to bed. They'll wake up, feel fully rested again, and they'll be ready to go, right? This one only affects the motor junction. Sensory function is not lost, so they can still feel sharp versus blunt on their legs and their arms and so on and so forth. Remember, Guillain-Barré, you would lose that sensation. With myasthenia gravis, you have sensation, you have sensory function. You can feel sharp versus blunt. You can feel that, right? Generalized myasthenia gravis involves a combination of muscle weakness. So the muscles of the mouth and the throat are usually affected. The limbs and the respiratory muscles can also be affected as well. So this is where we have it going from top down, right? That was that first picture of this whole slideshow. Remember that ball at the top of the pyramid there? It goes from the top down, right? And this is a neuromuscular junction issue. It can also affect the diaphragm, which is what we want to try to avoid, or if it does start to affect it, we want to know early on so that way we could take intervention. So this is the picture from your book. Don't you love these? Because we're looking here at the neuromuscular junction and the chemical transmission of acetylcholine, right? You see it coming off of the myelinated nerve fiber, right? The MNF right over there. And look, that myelin sheath is fully intact, right? So it's nothing wrong with the myelin sheath in myasthenia gravis, right? But we have the AB as antibodies, right? You see the antibody just sort of floating in there, right? AT is the axon terminal, and that's what we're looking at here. And so when we're looking at this, the myelinated nerve fiber is sending a signal, right? The antibodies are in there. And when we're looking at this, the antibodies have a physical structure that's very, very close to acetylcholine. So here you have a receptor site that sees something that looks like ACH. It's like, hey, you look like what I need to contract, so I'm going to let you bind to my site, or it binds to that receptor site, making it think that it's acetylcholine, when in fact it's just an antibody that's connected to that site. Well, if an antibody is taking up that parking space, and that's what you see in this picture, you see that antibody sort of taking up that parking space right here. If the antibody is taking up a normal parking space, then guess what? Is the muscle going to contract as easily if it doesn't have as much energy or as much signal to go there? Absolutely not. Right? So imagine that this muscle that we're looking at here is the diaphragm, right? We're going to have a very weak contraction of the diaphragm. That means a very weak inhalation, which means hypoventilation, right? Ultimately, right? So that's why some of these types of effects that you would see with myasthenia gravis could be atelectasis, right? Because are we going to be able to have full expansion of the lung tissue? Absolutely not. So this is going to be restrictive in the fact that the muscle can't contract, and it's these antibodies that sort of pretend they're acetylcholine and take up parking spaces that they shouldn't be taking up. They're not allowed to park there, right? All right, alterations. Obviously, when the diaphragm is involved, and not all cases involve the diaphragm, but when it is involved, you can develop what's called a myasthenic crisis, right? This is where you might have to put them on assisted ventilation, like mechanical ventilation, right? So if their diaphragm can no longer perform the primary function of breathing, it's weak, then we might need to put them on mechanical ventilation. That's just to help that muscle recover and recuperate until they're done with this. If it's not properly managed by the time it reaches their lungs, they can develop a lot of mucus, right? A lot of mucus accumulation, because if you're not breathing deep, is your mucociliary escalator as effective? No. When you do deep breathing, when you look at autogenic drainage, when you look at those deep breathing exercises, they help mobilize mucus. They help your mucociliary escalator be more effective. And so when someone is breathing shallow, they're going to have more mucus accumulation. And if that mucus continues to accumulate, it will obstruct the respiratory areas, right? That causes alveolar consolidation. And obviously with alveolar consolidation, that will lead to atelectasis, right? So we have this mucus accumulation that leads to airway obstruction, that leads to consolidation, that then leads to atelectasis. So you sort of see how this whole airway clearance therapy on neuromuscular patients becomes very, very important for your practice, right? So even though their X-ray may be clear, even though their breath sounds initially may be very clear, it might be a good case for prophylactic airway clearance therapy in these type of patients. So what are some risk factors of getting myasthenia gravis? So usually it's related to the ACH receptor site and the antibodies, and we already talked about the antibodies, and the big one here is the IgG antibodies. And like we talked about before in that funny animation picture there, they look like acetylcholine and they take up the parking spaces on the muscle. So they block the nerve impulses. They block actual ACH from parking on the receptor site on the muscle. And that's what's going to make the muscle weak in its contraction. So these antibodies, these IgG antibodies, sounds like it's important to know it's IgG. IgG antibodies will disrupt this. They block the receptor sites. They also accelerate the breakdown of acetylcholine. That means the amount of time that acetylcholine is available to be picked up by the muscle is reduced. And when we reduce the amount of time or the amount or the concentration of the and the time constant that stuff is available, that also reduces the ability for the muscle to contract. It also, ultimately, those antibodies can destroy receptor sites. This is bad. Not only does it block, it also breaks down the good stuff that's supposed to send the signal, and where it does bind, the IgG, where it does bind, it can actually destroy the receptor site. So this is a three-pronged attack. It blocks, it breaks down the good stuff, and it destroys where it does attach, where it does park in space, where it does park, right? It'll just destroy that area, right? So this is pretty prominent. I won't make you guys memorize these statistics over here about the 36,000, 60,000, all that stuff. That can change from year to year, so on and so forth. I want you to understand the big main parts about this process. So I would not look at those numbers, but looking at the three-pronged attack could be pretty important to you, and why the IgG can bind there, right? Peak onset in females is actually younger, 15 to 35, and older in young males. We're talking genetics here. Manifestations are usually, or things that lead up to it, extreme emotional upset, physical stress, right? Extreme temperature changes on these patients, which includes like a febrile illness, like a very high-grade fever, and even pregnancy has been known to be a risk factor for getting myasthenia gravis. All right, so bedside evaluation. What will this present like? So you have a patient in front of you. What are some of the textbook things that you would see at their bedside? All right, and I've included some pictures here. The hallmark sign, the hallmark of myasthenia gravis, is chronic muscle fatigue. In other words, they feel tired. They feel like they've just done a leg day, like, 5 days in a row. Like, it's that chronic fatigue that I've been to Waterworld and I'm just dead tired type thing, right? That chronic fatigue. They'll also have facial muscle weakness, and that's ptosis. And so this big picture over here with the eyeballs, you guys all see this? That's ptosis. See that drooping of that patient's right eye, or the right eyelid, right? And also, do you see how the eyeballs, right? Do you see how this eyeball is looking sort of a different direction than this eyeball? So that's something that you might see with this. So this is a ptosis. This would technically be blepharoptosis because it's a drooping of the eyelid that you're looking at here. And so you might see that uneven drooping. So that could look like a stroke type thing that's going on, right? We just have to sort of see and rule out different things like that. Diplopia is this guy here. Do you guys see this? It's that double vision. Right, where you hold up, hey, how many fingers do you see? And they're like, I see a lot of them. I don't know, right? That's that diplopia. So ptosis, that's the drooping. Diplopia, that's the double vision. So obviously you can see that their vision might be affected big time with this as well. They might have weaknesses that control their eye movement, which is what we've seen over on this eyeball picture over here. Difficulty breathing, speaking, chewing, and swallowing. Does anything there look important to us? Like the ability to protect their lungs from aspirating anything? Chewing and swallowing. If a patient's having trouble chewing and swallowing, if you have a patient, especially if you work at a place that has a lot of CVAs or stroke victims, then you need to be aware of this if they're on things like Thicken, if they're on swallow precautions, because that could mean that they could still have aspirated something, right? That still doesn't mean, just because they're on precautions doesn't mean it doesn't happen, right? So just understand that. An unstable gait, that's why I put the gait picture here. I don't know if that helps you. They're not going to be able to move or balance very easily as well. Their movements are going to be very unstable. And so they're a big fall risk ultimately as well. They're going to have weakness in their arms, their fingers, their legs, their neck, right? Especially the more that they use them. They'd be like, oh, I just need some rest and then I feel better. Oh, I just need some rest and then I'm better, right? Oh, I just need rest, I'll feel better. Like, that's the classic thing with this. You do not, I repeat, you do not see that with Guillain-Barré. All right, so those are some differences that I'm trying to compare and contrast for you guys between MG and GB, right? The muscles that control the eyes, the face, the throat are usually affected first. So this is why I'm focusing on the brain and the mind and the eyes and the face and the double vision, all that stuff. That's where it's going to manifest usually first. So that's a good sign to you that this could be a myasthenia gravis situation. So should we be more cognizant of doing pulmonary function testing to see if their diaphragm's affected yet or not, right? So this is something that you should be aware of. So usually it manifests first off in the eyes, the face, and all those things. Once that's affected, usually it can spread to the diaphragm, and then that will impede their ability to breathe ultimately, right? Because then the diaphragm can't contract. It becomes weak like the rest of their muscles that's going on with this process. So that's why it's going to be important, just like Guillain-Barré, to do pulmonary function testing that looks at the strength of the diaphragm, right? We're looking for diaphragm strength. So we want to see how strong the diaphragm. So we're looking at vital capacities, MIPS, NIFs, MEPS, right? All those things to help see how strong the diaphragm is. So we might do Q6, Q12, Q4, right? It depends how severe their FEV1 and their NIFs are. That's what we're going to be looking at with these patients. All right, bedside presentation. We already talked about what their eyes and their vision and all that other stuff might be going on with them. So sometimes it can be subtle, like they might just have a little bit of droop, or it might be intermittent where they get some rest and then they're good to go. Or sometimes this could progress rapidly. So it has this sort of uneven presentation progress, I should say, right? It could be a very rapid onset. It can be a very slow, subtle onset. Sometimes they might have normal health for weeks or months at a time, and then it just continues to go on. Usually they have most of their weakness in late day or evening, of course, when they're less rested, right? Sudden generalized weakness that includes the diaphragm is when we look at when it gets to its more advanced stages, right? Usually it's more pronounced in the proximal parts of the extremities. In other words, you'll see it in their shoulders compared to their fingers, right? The fingers would be distal, their shoulders would be proximal. So if you ask them to touch each one of their fingers to their thumb, they should still be able to do that. But if you ask them to rotate their arm at the shoulder, they might not be able to do that with good strength. I hope that makes sense, right? So it's going to affect more proximal than distal, right? More proximals of these extremities. With this one, with myasthenia gravis, the deep tendon reflexes remain intact. I'll repeat that again because this is an important comparison and contrast to Guillain-Barré. With myasthenia gravis, the deep tendon reflexes remain intact. In other words, they still have them. You can still hit the hammer in their elbow, the reflex hammer in their knee. You can still do those things, and they should still have those reflexes. Their respiratory rate can vary. It'll be normal with very mild, and then obviously as they get into more of a severe case, it might have like a very short episode of hyper or tachypnea, but it would be very, very short-lived. So more likely you're going to see a very shallow and slow rate in these severe stages here. All right, that's why it varies. It's not really clear that this always presents with hyperventilation or hypoventilation, or as far as like the respiratory rate is concerned. About tachypnea or bradypnea, it's not a linear thing. It's not a black and white thing here. That's why it says varies. Okay. Cyanosis in a severe case, right? Of course, especially if you start to hypoventilate with the severe case, then that's where you're going to see that cyanosis. Breath sounds, as you're listening to them, you're going to either hear very hardly anything because are they able to take a deep breath? No, their diaphragm's not working very well, so you may not hear a good breath. And then if you do, you might hear these allectatic or mucus crackles that are going on. That's why I have the picture there if you're curious. These pictures are more for me than I think they are for you, but if you want to use them, go for it, right? So when you're listening, you might hear that late inspiratory crackle, right? Or the fine crackles. That could be atelectasis, but if they have mucus accumulation as well, you would hear that roncorous, that continuous, that snoring noise, right, of a breath sound, and that would be that mucus accumulation as well. So you might hear it continuous throughout the respiratory cycle. You might hear it late inspiratory crackles, the fine crackles, which would indicate atelectasis. If you hear it throughout the whole respiratory cycle, that's an indication that it could be mucus accumulation as well. All right, so what will their X-rays look like? Well, just like Guillain-Barré, if it's mild, it will be normal, right? Nothing abnormal on the X-ray. It'll say normal, no sign of cardiopulmonary disease, right? It can be perfectly normal, especially if it's just their eyes and their face that's affected to start off with, right? So if it does affect the diaphragm, right? If the diaphragm has been affected, right? We're looking at the moderate severe case here. We're going to have increased opacities. It's going to be more radiopaque, right? This means that we have atelectasis. We have the closing down of the respiratory zone, and we have mucus that's starting to collect. We have consolidation, right? So one of the things that we could see is the continuation of a normal X-ray if we're being properly managed with this patient. In other words, we're giving them volume expansion therapy. We're giving them airway clearance therapy. And their diaphragm might be affected, yes. And if their X-ray is normal, that means we're doing our job. That means we're doing good airway clearance therapy. That means we're doing good volume expansion therapy. So you want a normal X-ray, of course, with this. But if we're not doing these things, if they do accumulate mucus, if they do start to have atelectasis and consolidation, then obviously you're going to start to see radiopacities, right? That's where you're going to start to see these segments start to close down. This is where the patient becomes prone to a pneumonia, right? So this is a good case or a good discussion for the patient care team on airway clearance therapy and volume expansion therapy. Okay, so on these patients, just like Guillain-Barré, we're going to want to look primarily at their diaphragm strength ultimately when we're doing this. So bedside pulmonary function tests are going to be pretty important on these patients. So you'll be doing these, and it depends on hospital policy and procedure. Our hospital policy and procedure was at least BID, right, Q12, and then if they were below a certain value, let's say 80% of what would be predicted for them, then we would do them Q6. And if they were below, let's just say 70%, then we would do them Q4, right? So each hospital might have its own policy on how frequent to do them, but when you're doing the bedside PFTs, you're looking at their volumes, right? Their forced volumes, right? This is going to be their forced volumes. So FVC is going to be one of your big ones to look at here. Flow rates, remember, it's not an obstructive condition, it's a restrictive condition. So remember, your volumes will be decreased with this. So the more severe it is, the lower your volumes are, right? That's what we're looking at here. Notice on the bottom it says maximum inspiratory pressure. Sometimes you might see it as negative inspiratory force. Oh, my handwriting with this thing. I'm going to have to get a better stylet one day. That's supposed to say NIF, negative inspiratory force. Same thing. So if the doctor asks you to get a NIF or MIP, they're just same thing, different way of calling it. Maximum inspiratory pressure, negative inspiratory force. How much pressure does it take, or how much pressure can they generate breathing in? Right, that's a NIF, or a negative inspiratory force, or maximum inspiratory pressure, and we want to record that value. And that's looking at diaphragmatic function. So you have to have a good strong diaphragm to force a breath out. You have to have a good strong diaphragm to force a breath in, right? And that's what you're looking at between the MIP and the forced vital capacity. You're looking at diaphragm strength going in, and then force out as well. So that's what the two primary tests that we'll be focused on is MIPS, MEPS, or FBCs, depending on policy and procedure. But remember, those are the ones that look at diaphragmatic muscle strength. So even patients on mechanical ventilation, I know you guys aren't there yet, patients on mechanical ventilation, if we think there's a neuromuscular component or a spinal cord injury patient, we might do a vital capacity on a ventilator. We might do a MIP or a NIF on a ventilator, and some ventilators actually have NIFs or MIPs on them, so we can measure these things to see if their diaphragm is strong enough for extubation to get them off of mechanical ventilation. All right, so on a blood gas, if this is moderate, if this is a mild issue, we're going to have a normal ABG, just like we've seen with Guillain-Barré. That's not going to change because this patient hasn't had their diaphragm affected yet. It's when their diaphragm is affected that's when we go into the moderate to severe category, which is going to be that acute respiratory acidosis, right? Diablo. No comments or sponsors here, but I was just trying to compare and give you a fun little picture. So in mild cases, it'll be a normal ABG, normal. Right, like I said, it won't be an alkalosis or anything like that. Very mild. And then in severe cases, it'll go to a respiratory acidosis. So mild, normal. And then when we're looking at an acute respiratory acidosis is when it's moderate to severe. All right, so oxygenation, this is a shunt-like process. We have blood flow going through the alveoli. What happens to our ventilation? Right, we have poor ventilation, so we have perfusion without ventilation, which is the definition of a shunt, right? And that's why they'll desaturate. That's why they'll have lower SpO2s and SaO2s and PaO2s, right? So we have perfusion without ventilation. So this is a shunt-like effect. It's not a true shunt where it's completely bypassing ventilation. We're just hypoventilating, right? And so that's why oxygen therapy could be indicated here to help with that shunt-like process. DO2 is decreased because CCO2 is decreased, therefore CaO2 is decreased, therefore DO2 is decreased. Now your DO2 is decreased. Remember the two factors in your DO2 equation are CaO2 and your cardiac output. Is this an issue with the heart being sick? Absolutely not. So remember, your DO2 is low because your CaO2 is low because your CCO2 is low, right? This is that whole downstream effect. So your DO2 is decreased. Your metabolic rate is actually normal, right? Your oxygen consumption, your ADV gradient, is normal in this case. O2ER is increased because DO2 is decreased, and your SVO2 is decreased because your O2ER is increased, and because your DO2, your starting point, your DO2 is decreased, therefore downstream, so will your venous saturations be decreased, right? This is that whole downstream type situation. Because I start off with a low DO2, I'm going to end with a low SVO2, right? It's that downstream effect. All right, so how do we diagnose myasthenia gravis? So sometimes they'll do some screening methods. Clinical presentation is going to be one of the big ones that they'll start with. When did this start? Was it a slow progressive onset? Sometimes it's faster than others, but they'll be like, oh, I feel paresthesia in my finger, or I'll feel weakness, but then I'll rest and then it'll get better. It's more common in their face presentations, like I said, droopy eyelids, things like that, or double vision. They'll take a rest. They just think that they're fatigued. They'll take a rest and then they'll feel better, right? So there are some bedside tests that we'll do, and so we'll talk about those upcoming. We could also do immunologic studies, especially looking at IgG, electrodiagnostic studies like EMGs, things like that. And then we're going to look at conditions associated with myasthenia gravis that might help us clue into a pregnancy, recent emotional stress, things like that that we talked about earlier. The Tensilin test is going to be one of the big ones that you'll see out there. I remember when I was doing clinicals at a certain university hospital where they were using this because we had a patient, I shouldn't say we, I was a student. They had a patient that had an abnormal presentation of a neuromuscular, and so they were doing the Tensilin test to sort of confirm between myasthenia gravis and Guillain-Barré because it was such an atypical presentation. They were trying to figure out between the two. And what this does is it'll block cholinesterase. Now, what cholinesterase does, if you guys don't remember, which how can you not? I'm just joking. Cholinesterase breaks down acetylcholine after it's been released from the terminal axon. So here's your terminal axon. It's releasing acetylcholine, right? These little dots are acetylcholine. What cholinesterase does is it comes in and it's like, I'll do like a Pac-Man, all right? And it's eating up all the ACH after it's been released. So it's normally, its job is to consume leftover acetylcholine, right? So it's just going to go and eat and consume, right? So cholinesterase's job is to break down excess acetylcholine, right? That way the muscle doesn't stay contracted for like days and days on end, right? It's just to help it get rid of it. So what this does is it blocks the cholinesterase from doing this altogether. It blocks the breakdown of ACH. Now remember, the condition here is that we have, here's the muscle tissue, and here's the IgG antibody that has those little dots on it that look like acetylcholine attached to it. So this means I have more ACH available for a longer period of time, so that way I can see if their muscle strength improves after I give them Tensilin, or this drug, right? After I give them this drug, if their muscles improve, if there's less drooping, if there's more strength, then I know that this is the problem. It's an issue with acetylcholine getting to the muscle site. So we're allowing the acetylcholine to stay in high concentration to cause that muscle to contract again. So this offsets the antibodies and should see an improvement in muscle function. And I hope this picture somewhat makes sense to you. I wish I could create animations for you. Maybe that's my next venture here. But here's the sort of downside or the risk that's associated with it. Obviously, it's not going to just affect your only one type of muscle in one area. It can affect other muscles like your heart muscle and cause a cardiac arrhythmia. And if it's severe enough, it can cause this thing called a cardiopulmonary arrest. So it's not without risk, and it's not that it will automatically send every patient all the time into arrest. It's just a risk that we have to be aware of. So if their heart's not strong enough, let's say this patient already has congestive heart failure, or let's say they already have an arrhythmia or a very sick heart to begin with, maybe we don't do the Tensilin test. Maybe we do something like the ice pack test. Maybe we move on to a different way of looking at this. This one's a little bit different. It doesn't involve a medicine. We're just going to use an ice pack, and we're going to put it on the eye that's affected, so that droopy eye that we were looking at earlier, for a couple minutes, right? 3 to 5 minutes. And then we're going to see what happens, right? It's considered positive when there's less droopiness, right, of the eye after we take it off. So when we're looking at this, if we see an improvement in their muscle for the ice pack test, if we see an improvement in their muscle function after we do the ice pack on their eye, then that could also be considered positive. Now remember, this one's 2 millimeters, so in theory you can measure it. It's just going to have a little bit more subjectivity than the Tensilin test. So you have this patient, they have myasthenia gravis. What are some therapeutic interventions that we do with this? Well, remember, this is not therapeutic, but this is diagnostic. But one of the things that we'll be doing on these patients is looking at their diaphragmatic function with bedside pulmonary function test. This can indicate to us when we need to start a therapy like assisted ventilation, or hyperinflation therapy or airway clearance therapy, right? They may not want to start airway clearance therapy until the diaphragm is compromised. So in that case, you're going to want to do this bedside PFT, right, to look for an indication for a therapeutic intervention. I hope that makes sense. Right, so forced vital capacities, maximum inspiratory pressures, aka NIFs as well. I just want you to be aware of that. They're synonyms. And then MEPs, maximum expiratory pressure. So how strong the diaphragm, all three of those are looking at the diaphragmatic strength. In ABG, when it's indicated, of course, the patient has a normal respiratory rate. They have normal pulmonary function tests. They have no saturation issues, right? And ABG is not necessarily indicated at that time. So mechanical ventilation, of course, when it's indicated, when their CO2s are above 55, when their CO2s are starting to climb. You'll learn later in Intro to Mechanical Ventilation when the CO2 is starting to get closer to 55. That's an indication for mechanical ventilation, or a pH of 7.25. This is just saying, hey, they're trending in this direction. They're hypoventilating, right? So that we might need to put them on mechanical ventilation. So greater than 45 and less than 7.35, they're trending. So that actually might be an indication to put them on the vent earlier than waiting till they're in complete failure. MEP less than 40 or MIP less than 30. So if you get a MEP of 20, right, here let's do an example. If you get a maximum expiratory pressure of 20, that's less than 40. We want a stronger pressure. So that means their diaphragm is weak. Let's say you get a maximum inspiratory pressure, or a NIF of 10 centimeters of water, instead of negative 10 centimeters of water instead of negative 30. That means they can only generate negative 10 on a pull in. That means that their diaphragm is weak. That would be an indication for assisted ventilation, right? A forced vital capacity less than 20 mils per kilo. Let's say it's 8 mils per kilo per ideal body weight here. That would be an indication for assisted ventilation, or for redoing the test if they didn't give good effort. All right, so what do? We see this patient has this, we're quantifying it, we're looking at their MEPs, their MIPs, their FBCs. Well, one of the things that they might do on this patient overall, so these are the top ones here are non-respiratory interventions. They might do acetylcholinesterase inhibitors. So this, remember, cholinesterase is what breaks down ACH. So if we stop ACH from being broken down, their muscle function should improve. And so that's that therapy to help their muscle function improve. I hope that makes sense. Immunotherapy, obviously, with IgG going crazy and pretending to be something at the site. Obviously, immunotherapy might be a good situation here. IVIG, like I said, that's what I most commonly see in these neuromuscular patients, including Guillain-Barré as well, right? IVIG, or they could do plasmapheresis. Thymectomy, if that's the issue. Of course, we talked about this being a shunt-like effect, so oxygen therapy. Airway clearance therapy, volume expansion therapy, we already talked about this. And then non-invasive or mechanical ventilation as needed. All right, quick review questions. What are some common alterations that occur with myasthenia gravis? I think there was, 4 things here. What happens when it affects the diaphragm? What are some things that happen there? Usually one leads to the other, leads to the other, leads to the other. What might you find? What are some bedside presentations? What are some ways? What would you see in their face? What would you see in their limbs? Would it be more proximal? Would it be more distal extremities? Would it be ascending? Would it be descending? Paralysis. What about their X-ray? Especially in a mild case, what would their X-ray be? What about in a severe case where we weren't doing good volume expansion and airway clearance? What would their X-ray show? What would an ABG be like in a mild case? What about in a moderate to severe case? Oxygenation, what type of process is this? What happens to their DO2? What happens to their metabolic rate? What happens to their SpO2? Why are those that way? PFTs, what would their PFT show? Volumes would be, flow rates would be, What general direction does the paralysis go again? Is it ascending or is it descending? All right, this patient has myasthenia gravis. What are some therapeutic interventions? What roles do PFTs play in this patient? These are all things you should be thinking about.